Assalamu alaikum dear doctors. In this video I am discussing a video station. So first we will watch the video, then I will discuss what type of question we are expecting from this video station. First question is that what I observe in this video. I can see there is an adolescent boy who is on ICU setting and he is on bedridden conditions. There is tracheostomy tube, 4-limb blood pressure, monitor is device is attached on him and there is NG tube also attached. And on this video I'm also seeing that the physiotherapist helping him, giving some therapy, moving his limb, and his condition is improved. And at the end of the video, and he is on go back to the normal condition. So on top, my diagnosis is Guillain-Barré syndrome (GBS). Now the description. So description is a high steppage gait, touching the floor by toes first, then by heel. The knee is high and flexed and foot drop. So this is the presentation of Guillain-Barré syndrome. So it is a case of bilateral high steppage gait for differential diagnosis. So Guillain-Barré syndrome is present with high steppage gait. DD is that first Guillain-Barré syndrome, then Charcot-Marie-Tooth, peripheral neuropathy, vitamin B12 deficiency, diabetes mellitus, thyroid, drug is vincristine, peroneal nerve injury, both side like trauma, hip and knee replacement, spinal cord disease, trauma, tumor and hemorrhage. Next, what do you want to ask in the history? So the history I would like to ask in GBS patient, that is the onset, course and duration, what make it better and what make it worse. Then we can ask number 2, any cranial nerve affection. Number 3, any history of headache, vomiting, especially at morning, and other sign of increased intracranial pressure. Number 4, numbness, tingling pain. Number 5, any change in behavior, abnormal way of walking. Number 5, moving upper limb, ascending paralysis, bulbar manifestation, dysphagia, autonomic manifestation, sphincter control, pee, poo, hypertension and heart rate. Number 6, recent any infections, pneumonia, mycoplasma, gastroenteritis by Campylobacter and COVID-19. Number 7, any recent history of foot ulcer, tropic ulcer, that is CMT, Charcot-Marie-Tooth disease. Vaccination history like OPV, rabies, MCV-C and flu vaccine. Drugs like vincristine and fluoroquinolone. And any chronic illness, diabetes mellitus, thyroid, traveling history, old paint and lead toxicity, and family history of Charcot-Marie-Tooth disease. So these are the history we will ask. Now, what do you want to examine? What are the examination we will do in this patient? First, ABC, airway, breathing and circulation, vitals, especially the blood pressure and spirometry and heart rate measures, and plot on growth chart. Full neurological examination, repo for speech and mentality, posture and decubitus, facial expressions, cranial nerve, facial and squint, device assistance, urine catheter, and general examination. Number 1, screen for wasting scars, abnormal position and movement, skin, stigmata and pressure source. Number 2, special shows. Number 3, gait, normal or tiptoe, heel or cannot, tandem and rubber test. Number 4, back. Is there any deformity, scar, skin, hypo or hyperpigmentation still in nappies? Local examination, tone, power, reflex, Babinski sensation, proprioception, position, light touch, coordination and cranial nerves. And also you do the examination, respiratory and cardiac examination and vision assessment. Investigation. What investigation we do in GBS patient? That is CSF, cytoalbumin dissociations, no cells, negative culture, high albumin and normal glucose level we find. So normally high albumin we find in CSF. EMG, acute denervation present. NCB, nerve conduction velocity slow. MRI spine for spinal cord lesions. Anti-ganglioside antibodies. Antibodies against the Campylobacter. If unilateral X-ray pelvis to rule out the fracture. Bedside blood pressure, ECG and spirometry. How will you manage him? So management of GBS is that admission to ICU, informed consultant, daily spirometry with FBC follow-up because respiratory failure is sudden death and life-threatening. IV immunoglobulin, plasmapheresis, physiotherapy and rehabilitation, steroid if intermediate or relapsing course. Team. What are the team involved? Neurologist, pulmonologist, physiotherapy, occupational, speech and language therapist, that is SALT. Dietitian, ophthalmology, cardiology, liaise with school and skin care for pressure ulcers. Follow-up is that neurological examinations, cranial nerve examinations, spirometry, FVC and blood pressure. When bad prognosis? So bad prognosis of GBS patient are when cranial nerve affections, respiratory affections and bulbar affection, no improvement after 2 weeks. Difference between polio and GBS. So polio, what happened? There is no cranial nerve affection, no symmetry, no sensory affection preceded by severe muscle pain, no autonomic affection, CSF lymphocytosis and stool virus. We know that polio is already eradicated from this world. Now, note about Charcot-Marie-Tooth. So, Charcot-Marie-Tooth disease, we do the test, genetic study, genetic counseling for family, and support. And team involved are consultant, pediatrician, ICU consultant, neurologist, pulmonologist, SALT, ophthalmologist, physiotherapist, occupational therapist, dietitian, dermatology for care of bed sores, lies with the school, psychological support to the family. If GBS, the affected nerve is peroneal nerve. So remember, peroneal nerve is affected in GBS. So this is all about GBS video station that is frequently coming on the exam. Please do subscribe and share. MRC PCH with Dr. Emma Chaudhuri. Thank you.